we're hearing that some people, I think Sam Altman actually talked about this publicly.
Overdose.
With Kara Swisher about what he thought, where he overdosed. Actually, a compound pharmacy issue he thought was what did it. I trust him to do the right calculation, so it does sound like that was a compounding pharmacy issue.
Could afford it just to buy the farmer, a great option.
I think back then people were just getting them where they could. I didn't ask him why that happened. But nonetheless, get the dosage right. Make sure you're getting the right stuff clean. But he talked about the kind of lack of motivation, which many people have described anecdotally, like, okay, lowered their food drive, but lowered their drive, period.
Yep.
Makes sense, depending on which pathways are being affected. But do you think that's a real effect? Is that something that people need to be concerned about? Do you think people can microdose this stuff? Because a lot of people are microdosing it, regardless of what their source is. They're taking a lot less than the kind of standard clinical trials will be. And we're leaving out retatrutide for now.
Yep.
Because it's so new. We're going to talk about it, but I'm talking about the standard.
Semaglutide and tirzepatide. Yeah. So you have your, semaglutide, which is Ozempic and Wegovy. The Wegovy is the FDA-approved version for the weight loss. For tirzepatide, you have Zepbound and Mounjaro, Zepbound being the FDA-approved version for weight loss that allows them to keep their patents for longer. These medications are good, kind of transforming medicine, especially where I practice, right? If we kind of zoom out, our medical system, if we didn't have these interventions, was going to collapse on itself thanks to the obesity, prediabetes, diabetes epidemics. Because we don't have enough clinicians or finances to get everybody who was pre-diabetic in the last 20 years, and they all transitioned to diabetes and ended up with diabetic medications and dialysis and eventually cardiovascular disease and all these things. We don't have the resources to take care of all these people. Like, our medical system was going to collapse, and there wasn't enough finances to take care of it. Now these GLP-1s are coming in and kind of transforming that phase of medicine, because now we have a chance to dramatically change the rate of obesity, diabetes, prediabetes, and all these cardiometabolic disorders. So where do we stand? We needed something to happen. I mean, ideally, everybody, would get morning sunlight and eat only healthy foods, unprocessed foods, and have low stress and sleep great at night. And maybe no one would develop to become obese. But the reality is people become overweight, obese. They get stuck in that hole. And if you just try to step out of the hole the way you came in, sometimes that doesn't work. You need a different path out of that problem. And that's been, the diet and exercise literature for the last 40 years. Millions of books have been sold on how to get people leaner. We now have interventions medically that can dramatically change people's weights for the first time. We've had drugs in the past that, 5, 10% of body weight. Now with the GLP-1s, we're getting 10, 20, even 30% of body weight being shaved off of people, especially with the new retatrutide data. Is there a free lunch? That's the big question. Like we kind of talked about earlier, there's always been these medical mishaps that have happened. So far, the data is very promising when it comes to GLP-1s, and that we are now reversing this rate of chronic disease. Is it going to stay that way? That's a good question. I'm cautiously optimistic when it comes to these medications. I've been prescribing them since I was a resident in my VA clinic. I was putting all these vets that are 300 pounds on GLP-1s. They were losing 50, 100 pounds. Before it was FDA approved for weight loss, we knew that if you put diabetics on this drug, they would lose weight. Thanks to a lot of the bodybuilders, that kind of pioneered that.
When did the bodybuilders first start using GLPs?
Late 2010s.
Wow.
Early, and then the signal. I don't think Novo or Lilly wanted to make these for obesity. They were focused on making diabetes drugs. Because if we zoom out even further, this is another animal-derived compound, right? It's found in the saliva of the Gila monsters. GLP-1 was discovered. It's too short-acting to have worked on its own. Then pharmaceutical companies, this is where you got to give pharma their credit, they developed these drugs into more functioning versions that had longer half-lives and could stick around in the serum for longer to have the clinical effect. So then we started noticing that diabetics, like my grandma got Byetta, which was one of these first GLP-1 drugs like 25 years ago. It was out of all the drugs she was on, the reason I went into medicine, that was the drug that changed her whole trajectory, because she had less insulin needs and she was losing weight and more energetic. So we had seen the effects on diabetics, and then you get liraglutide, dulaglutide, and then eventually semaglutide is the blockbuster. But you get all these positive effects coming from these drugs on diabetics. It gets translated into obese people and overweight patients. The question is, what is the long-term effect of this? Do you have to stay on this drug forever? Can you titrate off? The pharmaceutical companies have not given us good guidelines on that. They've shown us what happens if you stop the drug. You can max out on maximum dose tirzepatide, pull the brakes on. People tend to sometimes gain the weight. Some people don't, but some people will regain back to baseline. Because if you think about it, the better way to think about weight loss It's the calculation your brain does every single day with all the different hormones and peptides that are made from the gut, the GIP, GLP, glucagon, insulin, testosterone, estrogen, all these things can kind of modulate. And there's this thing called a set point theory or settling points. And they integrate, should I eat or not eat, right? So the GLP-1 is a giant signal to the brain of don't eat. So we're modulating this pathway. What happens to all these young kids that are 18, 19 years old on 5 milligrams of retatrutide that have lost 30, 40 pounds? Are they going to have to be on that for life now to maintain that weight?
Can I ask you about that? Because when people say, perhaps you have to be on a drug for the rest of your life, I think, okay, what's the availability? What's the cost?
Yes.
What's the real world cost of taking 6 months off because you can't access it? There's a shortage and maybe better drugs will come along. Like, I don't necessarily have a problem with it. Although if you talk to type 1 diabetics, in the old days, they weren't crazy about the idea that they had to constantly inject themselves with insulin. Now there are better delivery devices. I kind of feel like eventually there'll be some slow release polymer that will just kind of give you a microdose of it. You could dial it up if you want.
Like, there's oral pills now?
Personally, I don't worry so much about like, for the rest of your life. I worry more about the much shorter life if people are obese. But what about these brain effects? I do worry about a brain that's developing in the context of a 1,000-fold or more increase in these GLPs. Because when we had Zach Knight on the podcast, he's not a clinician, he's a scientist up at UCSF, Howard Hughes investigator, which means he's like a superstar and deserves to be in that category. He described that the diabetic drugs would increase GLP by like double, quadruple, but the weight loss effects weren't really there. But the drugs that you rattled off a few minutes ago, Mounjaro, Ozempic, et cetera, and certainly retatrutide, we're talking about 1,000-fold increases in GLPs. We don't know what the long-term effects of those are on like neuroplasticity and learning. Could be great.
Yes.
Could be positive. We shouldn't always assume those effects are bad.
Yeah, like the effects for like, let's say a 60-year-old pre-diabetic diabetic on Alzheimer's disease seems to be potentially positive. I think the study last year didn't show a good signal on our Alzheimer's prevention, but we know diabetes and cardiometabolic disease speeds up that transition. So controlling insulin dynamics might be beneficial there, and obesity is not great for Alzheimer's risk. The question is, what about for like these cognitive effects? Is the effect happening from the drug itself? Is it from misuse of the drug, too high of a dose? You're not getting enough electrolytes, you're not getting enough micronutrients, macronutrients, your blood sugar is low. Because a lot of these patients, the way we approach it is training wheel effect when it comes to GLP-1s. Okay, you come to us, you're a patient, you want to use GLP-1s, we'll give you a lowest dose as possible that has an effect for you, GLP-1, in conjunction with lifestyle modification, dietary advice, exercise programs, et cetera, et cetera, et cetera. And then hopefully peel away those training wheels or keep them on if you need them until we get to the endpoint that we want. Now, when people do it that way, I don't hear a lot of these effects anecdotally from Berkeley patients that we hear about online, where people are like, oh, I'm depressed, I hate my life from these drugs. And the question is, are they just, a lot of people have low blood pressure from these drugs because they're not, consuming enough electrolytes or enough food, period. Because like some people will take a mega dose of these drugs and end up not eating, like a day goes by, they've eaten one meal. That's not conducive to good, feeling good. Everyone, the reason people are obese in the first place is because eating is such a pleasurable experience for humans and a social experience, et cetera, et cetera. The other thing is, if you're not eating with people on the same table, are you having less of that socialization aspect? A lot of times you meet up to eat or drink or whatever it may be. So I'm very curious when it comes to the cognitive effects. Is it from the drug directly interacting with the receptors in the brain? When we've seen that the right amount of dose decreases inflammation in the brain? Or is it because of the social aspects of the drug changing the way you behave and therefore leading to negative output?
How dare you think of confounding variables? No, it's so cool because you're willing to go outside the box and say, hey, listen, this might be due to some of the downstream consequences of reduced appetite.
Yeah, and we know the literature shows that people now are having less alcohol cravings from this. It might be changing the way the dopaminergic signaling is happening in the brain, which is concerning, right? Because a lot of people will be stacking this with, ADHD medications. They might be using some of these peptide stimulants, Semaxilin, whatever it may be. So the question, because what happens is people go to these websites, they buy one peptide, and they got a great result. And they'll be like, let me add 3 more peptides on.
Accessory peptides.
Yes, it's an increasing AOV problem. So the average sale value goes up from these research sites. Yeah. We'll see where GLP-1s go. But the reality is it's here. There is no pre-GLP-1 world for us as clinicians, as health enthusiasts. We're in a post-GLP-1 world, and everything kind of dictates downstream from that.
The people I know who've taken these, and I don't know exactly which, are taking much lower dosages than were prescribed to them. And they are indeed sharing them with getting the prescription, then people are sharing them, people are cost sharing. Now people are trying to get them from other sources. Several of those people say they feel like they can think better, but I told them, well, yeah, if your insulin sensitivity is improved, if you're carrying less body fat's an endocrine organ, it's you need some body fat, but there could be a number of reasons for that. I don't know if these are direct effects on the brain.
Yeah, well, leptin sensitivity increases as you decrease the body fat mass. There's GLP-1 receptors on the POMC neurons in the brain, and no one's kind of examined what that means downstream for the leptin-melanocortin pathway, and what that means for energy status, thyroid hormone production, reproductive status. We know a lot of people are Ozempic babies, in that a lady will be subfertile or infertile, start a weight loss drug, and then find out by accident she's pregnant.
Was she obese before?
Yeah, these are overweight, obese women that are having their fertility improve as a result of losing the weight. Because we know your leptin status is a key driver of fertility. Because if you're having low leptin levels, you're starving, you shouldn't be fertile. If you have too much leptin and you're leptin resistant, you shouldn't be having kids either. So both of those things kind of get modulated by these drugs as well.
There was a science paper some years ago that leptin hitting a certain threshold is actually what signals the onset of puberty in females. Is that still considered true?
I think that's part of it.
Makes sense, like enough body fat to signal that there are enough resources, and then animals, or that was an animal study, or the idea was that people perhaps also females become reproductively competent at the point where there's enough energetic resources that, interesting.